Okay, well, we'll do a blood gas.
Baby Booker?
Yes. This is a 26-weeker who was born at a community hospital that does not have a NICU, so they called MCV to transport the baby to our NICU for care. We got to the hospital, intubated the baby, put a breathing tube in and had the baby hooked up to a breathing machine. So we did an assessment and made some adjustments in the breathing tube. We drew some blood to see how well the baby was getting oxygen in her blood and getting rid of CO2. We also drew some blood to make sure the baby doesn't have an infection. We're going to start antibiotics.
Call to see how the baby doing.
Okay. Great. It's nice to meet you.
Nice to meet you. Let's try to get
Good. Okay. Yeah, we're just moving slow. We're monitoring her heart rate, blood pressure, and her respirations, and also the amount of oxygen in her blood. She has an IV going that's giving her some sugar water to keep her well hydrated and keep her blood sugar up. So all in all, she's doing really well for a 26-weeker that's been born in a community hospital and has to ride in the back of an ambulance and her little rubber baby buggy bumper here for about an hour and a half.
Yeah, looks like that one. Here it is, hooked up to the back.
Okay. So we've arrived back here at VCU Medical Center NICU. We've put the baby in a giraffe incubator and given report to the bedside nurse and the attending physician. They're making some adjustments again with the tube placement and putting the baby on a breathing machine. And she did well doing the transport. She'll get antibiotics probably pretty quickly, and a blood gas, probably an x-ray. And we'll see how she does.
Welcome to our newborn intensive care unit here at VCU Health System. We have been providing care to critically ill and premature babies for over the past 40 years, nearly 20,000 infants.
And my role here has been in the design and finally building of this newborn intensive care unit. The three primary areas of design that we focused on were controlling sound, controlling light, and making the environment such that it was not hostile but actually welcoming to the family and to parents.
We're only one of about 50 centers in the entire country, and we're one of the first in Virginia, the only in Central Virginia, to develop this concept of a single family room. Historically, 40 years ago, when the first newborn intensive care units were designed, there were these large baby barns, and in the baby barns were infants lined up in a row, and their technology was often loud and large. And as one infant's alarm went off, it disturbed a number of other infants in the room. And so it really wasn't conducive to these developing babies getting adequate sleep and rest. And there were also great problems with cross-contamination and higher infection rates. So in our single-family room, we really are trying to provide developmentally supportive care for these babies in an environment that's individualized for their needs, and hopefully decreasing the risk of infection.
Before, when we were in one big open room, you could see what was going on with your other patient across the room, or if a nurse was in trouble, all she had to do was yell out. With us being in patient rooms, that now brings up a whole new idea of what happens if someone's in there and they need help. We have a nurse call button in there if the parents need assistance. It rings to our phone. It's similar to a cell phone. So all of our alarms will come to this. We also wear tracer badges so that we can be located at all times. If the clerk needs us, whether it's a phone call, they can transfer it to our phone, or if for some reason we're not answering our phone, they can look up on a big TV screen and find out where we are based on our badge.
With this monitor here, we have a split screen. This patient here is the one that's at the current bedside. My other patient is actually down the hall, and you can actually pull up their sats, their heart rate, their blood pressure by double screening the monitor. So you can monitor it while you're in your other patient's room. So if my baby was to desaturate, first you'll realize that on your monitor that the desats are here, and it will start blinking red, and it'll go to your phone, also to the call center, the nurse's station, and if you're unable to get to the monitor, your buddy will get it.
Several people have been involved in designing this unit. The things that we looked at regarding acoustic ceiling tiles to lower the stimulation and noise for our patients, the rubberized flooring to make it easier on our backs, but also to absorb the noise yet again to decrease the stimulation for the children, and then trying to make it yet a family-centered environment so that the parents actually have a lot more privacy really than they did in our old unit. Everything that we would possibly need is in this room within an arm's reach away, so that we're fully prepared for any type of situation. Even the kids that are getting ready to go home have full equipment in their rooms because you never know what could happen. This is one of our newer giraffe beds. It's called a Giraffe Omni bed. It's made by GE, and it's sort of like the Cadillac of all beds. You can use it in an incubator mode, which is how it's set up right now, and we use this for our smaller babies. Or the top can lift off, and you can use it in a warming table mode for a bigger kid or a sicker kid that you need to gain access to relatively quickly. This is the pull-out couch for the parents. We have an armoire for the families to put their belongings in, and then we provide locks, so if they want to go off the floor, then they can leave their personals and they are secure. And then we have a refrigerator in every room, which is great. We highly recommend breastfeeding and try to do everything we can to get the parents to do that if it's something they're interested in. And so that way we try to not have the breast milk leave the room if we can help it.
I have been in the NICU for 35 years, but the primary focus of the last 30 of this has been education. Not only do I do education for new employees, I also love to teach parents. I enjoy seeing new nurses grow and develop and become very strong, capable leaders. I also enjoy watching a baby go home to a parent that feels that they're ready to go, so I really like doing that.
Once we get report, then you start your day, which means you generally organize your work around who needs to feed first. We have those who feed every 2 hours or every 3 hours or every 4 hours. We cluster our care, which means we do an assessment and we do vital signs, give their medications, and then feed them. So we're clustering care so we're not constantly disturbing them, and they can use their energy and save their calories to grow.